So let's see here. So the first theme is probably more in the sort of active surveillance phase, some general questions about the disease. And maybe I'll start with Dr. Ferrajoli. First question is, what percentage of CLL patients at diagnosis may never require therapy?
It's about 20 to 25%. Those patients, those people are going to have what is called smoldering CLL, where you usually have the favorable prognostic factors, such as a deletion 13q, your white count is relatively low, you don't have any anemia, thrombocytopenia, and a very minor enlargement in lymph nodes. So there is about 20 to 25% of the patients that fit these characteristics. Beta-2 microglobulin is usually low, below 2, and those have a really good chance of never needing treatment.
Great. Can everybody hear okay? Maybe just move the microphones closer to you when you answer. Sorry about that, I should have reminded.
Oh yeah, we didn't think about that. So it's about 20 to 25% of the patients, of the people that are initially diagnosed, have what we define smoldering CLL. That means a fairly low white count, favorable usually features such as a deletion 13q, low beta-2 microglobulin, no significant enlargement in lymph nodes, no anemia, no thrombocytopenia, and these people have a good chance they'll never require treatment.
Great.
Often females.
Also great. So for Dr. Lamanna, so this is kind of maybe a follow-up to that. So as an active surveillance patient, how do I deal with the uncertainty of not knowing if I will ever need treatment? That mental health challenge, that's a major mental health challenge.
Wait, sorry, what was the first part?
If, while on active surveillance, how do you deal with the uncertainty of not knowing what your future is going to be?
Yeah, absolutely. I mean, I think this was a question that I was talking with some of you all yesterday about, and this is difficult, particularly for those folks who are newly diagnosed in the room. It can take a while to kind of wrap your head around this new diagnosis, right? So for many conditions, whether they're cancer or non-cancer, oftentimes there's a treatment that's offered, right? If you have high blood pressure, you're put on a medicine. If you have another cancer, usually we're trying to cure it or get rid of it depending upon that cancer. And here all of a sudden you're telling you have a new chronic blood condition, and we're gonna watch and we're gonna observe. And for a while that really does play a little bit of a mental head game on you. And so I think it takes time, it takes a lot of support. A lot of people initially, always feel that anything that is, if they feel an ache or a pain, is that my CLL, is it related? And I think it takes a little bit, it takes a team. I usually see those folks when you're newly diagnosed quite often in the beginning, just for more reassurance. And so, sometimes just having those appointments with your team, or just, again, there are lots of support groups. And so I think, you should take advantage of, those types of opportunities. There are some people that I think benefit from reading, and there are some people who probably don't benefit from looking online. The internet is good, but it could be really dangerous because you don't know, you'll Google something, and the doctor Google, and you'll be like, oh, is that me? Is that me? And so I think that if you're one of those, it might be time to just pull back. So sometimes, not, taking a moment to think about things that make you happy, do get involved in exercise, friends and family, things that support that way. If you need counseling, there's nothing wrong with that either. I think people have this big barrier about, getting intervention, seeing a psychologist or a psychiatrist. And some people just need a little help in the beginning. Usually after a year or two, things start to settle. When you get in a routine and you're seeing your team and you kind of understand where things are going a little bit, and you're more used to what it means to have this, condition that we're actively monitoring, but you don't need treatment. And as I said, there's a benefit to that. You get to stay on the sidelines as the research continues, and you may not get exposed to therapies, or therapies may change and evolve and we replace them. So think about it that way. For some people, I've learned from you all, for some people, it's been, the diagnosis in a way has been a life changer for them. They all of a sudden go, I need to focus on some good things. change my life, start exercising, start being with friends and family, taking vacations, start working a little less. So, I think that sometimes we have to take a cloud and make it something sunny. So I think that there are different ways, but, try to avail yourself of all the things that are out there for you, and there's lots of support for you. I don't know if I quite answered.
Yeah, I think that's all excellent advice. And yeah, I mean, I think along those lines, I think, peer support is fantastic. Family support is fantastic. Most cancer programs, now will also have additional supports available to patients and families if there are challenges dealing with coping with the illness and other aspects of their illness. So, and again, a good family doctor is, gold if you have a good family doctor and resources that way. To support those sorts of challenges. It's very, very common. I mean, it's almost normal in a sense, right? To have those sorts of worries around a diagnosis like this. So this is a tough question, I think, but it's okay to ask tough questions. Sorry, Versha, you're next. No, so it's not to be funny about this. It's not a funny question, but the question is, we know that CLL is incurable, but should I expect a shortened life expectancy because of the diagnosis?
So that's a very good question. I think it really depends on kind of your particular type of CLL. And so yesterday we went over the different ways that we can classify patients into low risk, intermediate risk, and high risk CLL. So if we take the older literature, we could say with the treatments we had a long time ago, maybe those patients with more aggressive conditions may have had a shortened lifespan. But I think we're in a situation now where the needle is moving and we actually don't have a lot of information because we don't have the long-term data to say how these newer treatments that have basically rescued a lot of patients who were in that situation 10, 15 years ago and how that has impacted their outcomes. So I think the reality of the situation is the intermediate and low-risk patients are likely living their best life and they're going to not have anything to worry about. But that high-risk population that is in that kind of high-risk category, we're still learning about how their disease can be better controlled with the medications that we have. When we showed a lot of those, what is your molecular profile, what treatment you get, and you can see that sequencing. The sequencing keeps changing, and we keep adding things to our armament. So the reality is when we look at the causes of death and that Dr. Gibson had showed yesterday, it was very few people that were passing from their disease itself. Some of it was due to other medical conditions. And so if we take all of that information in combination, I would say most patients with CLL would live the same life expectancy as the average person in their age category. But there will be some unique features of certain individuals where that may not be true.
Good. This question is perfect for Dr. Gerrie. We're just talking about she's working on creating a Canadian database looking at Richter's transformation. So this question is, what do we know about what causes CLL to transform into lymphoma, and what are the signs and symptoms which precede transformation?
I think they're on.
Can you hear me? Not on that.
Yeah.
Oh,
yeah.
yes.
Yeah.
Okay,
Yeah.
perfect. There's no light. Okay. Great question. And I realized yesterday, I don't think any of us actually touched on Richter's transformation. So it's been interesting over the last little while. While the treatments for CLL have improved so much, some of the focus is actually now shifting to trying to improve our understanding and treatment of Richter's transformation. So for those of you who may not know, this is a situation where it's actually similar. Anyone with any chronic blood condition, so we have other types of low-grade lymphomas, for example, CLL, these have a small chance of switching, or we say transforming, into a more aggressive lymphoma. And when it happens in CLL, we call it Richter's transformation, based on the person who first described it a long time ago. So when that happens, people usually notice a change in symptoms. So all of a sudden, there might be a sudden kind of increase in symptoms including night sweats, that's a common one, drenching night sweats in particular. You might notice one particular lymph node start to grow faster than the others. People might have fevers and weight loss, so more signs of what we call a more aggressive lymphoma. And really the main way to diagnose it is to get a biopsy. So usually if somebody does have one lymph node that's all of a sudden growing faster and they have these symptoms, we will try to get a biopsy of that. It's often a situation where we use a PET scan if we have access to those. So that's a special kind of CT scan that we don't usually, at least in most centers in Canada, we don't usually use for CLL. It's not that useful. What it does is it gives you, you have a dye, which is like a sugar, that goes in, and then active cancer cells will eat up that sugar, and then it lights up on the scan. So CLL cells don't light up very much, so that's why it's not that useful, but aggressive lymphoma cells do light up. So sometimes we'll do a scan and we'll see that one lymph node is really lighting up more, and that's one that we might target to get a biopsy to look to see if there is evidence of this Richter transformation. So we do have to treat Richter's transformation. It's usually treated with more intensive chemotherapy, not typically what we use for CLL. But the good news is that our goal is to actually cure that. Those aggressive lymphomas are potentially curable. So our goal is to treat it. Usually people need cycles of chemotherapy. We treat it, get it into remission, and we hope that it never comes back. The underlying CLL will also get hopefully treated at the same time, but that we do expect eventually, as we know, CLL is not curable. Eventually that one will creep back. So the standard treatment that's still essentially the standard of care in most places around the world is with the kind of chemotherapy we use for what's called diffuse large B-cell lymphoma, and it's called R-CHOP chemotherapy. It unfortunately doesn't work as well as when we use it for typical diffuse large B-cell lymphoma. So now there's a lot of research into how we can improve upon that. And actually a big piece is adding in all those novel drugs, those targeted drugs, into the treatment with R-CHOP. So there's been studies adding in venetoclax, there's been studies adding in BTK inhibitors, there'll be studies adding in the new BTK inhibitors, like some of the non-covalent BTK inhibitors, and then studies looking at some of the other treatments we heard about yesterday, bispecific antibodies, and then also combining all these things together. So it's actually a really active area of research right now, and I think we're going to hear more and more about treatments for Richter transformation in our upcoming meetings and research sessions. Yeah.
Yeah. Any other comments from the panel? I mean, I think
Cole's notes on Richter's.
It's
see the
also
head nods. I feel like Dr. Ferrajoli.
yeah, it's also good that they seem to be becoming less common now that we have those effective treatments up front. So
Yeah.
still an issue, but
Yep. Great. Okay, we're going to switch gears a tiny little bit. Dr. Ferrajoli, you're up for this one. This is another tough question because we get it every single day in the clinic, and it's about you can phrase it any way you like, supplements, complementary medical approaches, vitamins, green tea. The question is, what's the latest research around what patients might wish to consider as it relates to vitamin supplementation, supplements, or other alternative therapies?
so yeah, this is a common question, and I think we can break it in two different components. That's what I usually do with my patient. One is what are potential risks for those supplements. So we all know that our bodies are fairly sophisticated machines, and any excess of vitamins or supplements that you assume orally will need to be processed and will need to be eliminated. So most of the time, by taking those mega vitamins, very high dose of vitamins, we really put our body under a little bit of stress to eliminate what is the excess. So what I usually say is that particularly when patients are starting treatment, I really ask them to stop the vitamins and the supplements because I'm concerned that by being processed by our liver, eliminated by our kidneys, they may interfere with the treatment. And if there is any changes in your liver test results or any changes in your kidney test, I cannot attribute that to the supplement. I have to blame the medication. So that may cause a change in the dose of the medication or a temporary stopping the medication. That is something that I don't want to do. Once the treatment is well established, if my patient say, I really want to take this supplement, then I'm okay as long as they reintroduce one at a time so that we can monitor and follow and see what we can do. Regarding data, there is very little data on supplement. There are some laboratory results that shows that curcumin that is in curry may slow the growth of the CLL cells, but those are fairly old results and they are only in the laboratory. The colleagues at the Mayo Clinic ran a clinical trial with a green tea derivative, and they saw some benefit in, again, possibly slowing the progression of CLL. However, the exact dosage and compound that they used is not available commercially. So it's always hard to say, yes, take green tea, but how much green tea? I'm not sure. And again, for green tea, it's okay to take green tea if you like it, but keep in mind that most green tea have some caffeine, so they can cause palpitation, and like all the teas, they tend to be pretty acid, so you need to make sure that they don't bother your stomach. There is also a very small study out of the University of Alabama, I believe, that showed that during the winter, taking some ginger supplements may reduce the risk of respiratory infections. So that's another thing that could be considered. But this is pretty much what I know about this topic. I have to say that over the years, I've seen different waves of special honey from the queen bee, some calcium from the coral of, exotic seas, but they tend to go in waves and then they go out of fashion.
Dr. Lamanna?
I just want to add that I think if anything, just to echo what she's saying, if there's anything that, there's a lot of things you can get online or read about, things for cancer. And the problem is we just don't have a lot of data. And so I think anything, whether you're prescribed, you're taking it over the counter, you're ordering online, you're going to a nutrition store, you need to tell your physician what you're taking, because there could be, forget about even, she just mentioned about the interactions with the therapy you might get for your CLL, but sometimes there's also interactions with your other medications you might be taking for heart disease or diabetes or something else. So there could be drug-drug interactions that you're unaware of that can increase risk of bleeding or other things, and so on and so forth. So it's really important. It's not that I think that everybody thinks that physicians don't want to, that we're like naysayers about, trying different things. We understand, obviously we're trying to find, medicines for the CLL. So we're all searching to help everybody. But the point is, there's just a lot of lack of data, and what might help one cancer may not be beneficial to another cancer. So I don't think we can extrapolate that if you read some cure for cancer online, that it's going to be relevant necessarily for your CLL. So it's just really important because we want to do no harm. We want to make sure that you're okay. Most of us will give lots of leeway with our patients with some of the things they might want to try. We just want to make sure your organ function's okay. We might want to follow something more closely. And so I think it's just important to bring what you're doing up so that everybody's on this, we're part of the same team.
Versha?
Can I just add one more thing? I also acknowledge the fact that at this point in time, especially in the newly diagnosed patients, there's a vulnerability of the patients as well. And there's a financial toxicity that comes with, ordering these things or getting prescribed something because you think it may benefit you. And so I think that's another piece that I always discuss with my patients as well. Like, you're free to do what you want to do in those early stages when you're not on treatment and it doesn't cause you any harm. But I also want you to think about the fact that we don't actually know how much is good, what dose needs to be taken, and that could come at a significant financial cost to you as you're buying these things that may or may not benefit you. So I do want to bring that up, that we don't want people to be taken advantage of either.
Can I just add one
Yeah,
more
of course.
thing?
Yeah,
We all have lots to say on this. No, I was just going to add that actually the vitamins that I think, if you are interested, so it's not unreasonable to take a multivitamin and vitamin D. I would say those are the main ones. So vitamin D, 1,000 units or even 2,000 units. Tiny little pills, easy to get over the counter. Particularly in Canada, we're probably one of the countries with the most vitamin D deficiency. And so that for general health is recommended. And so that's what I usually recommend for vitamins.
Definitely.
That's great. I think we'll maybe move on to the next question. That's a great discussion. I think that's all, very appropriate advice and guidance for you around this topic. Let's see. Maybe so the question about prognostic markers, specifically around IGHV and whether or not it changes over the course of the disease, and maybe a general comment about, again, we talked a little bit about this yesterday, but a general comment about prognostic markers and how you approach ordering them kind of in the active surveillance and later in the disease course. Maybe, I think we're actually at Dr. Lamanna in the order here.
We probably will need
We can get some Canadian perspective.
I think we can have the U.S.
Yeah.
style and the Canadian style.
There's going to be a little bit of a difference. I mean,
I think it's good to hear both.
I think in general, just a general comment about the prognostic markers, and then we'll switch about a little bit more specifically U.S. and Canadian, I think, is a little different depending upon reimbursement and things. The chromosomal abnormalities that were talked about yesterday, so that was that FISH test, that fluorescent in situ hybridization, where you're looking at the different chromosomal abnormalities, of which many patients with CLL have a chromosomal abnormality. And again, you aren't born with these are associated with your CLL cells. They can change over time with therapy. So you probably heard many of us talk that, oftentimes if somebody needs new treatment, we're going to be checking those chromosomal abnormalities again, because they can change. You can evolve to develop newer chromosomal abnormalities, oftentimes, sometimes not as favorable, because your disease may be becoming more resistant as it evolves, and so we do check those again. The mutational status usually does not change, so typically if you have that test done once, you're either mutated or you're unmutated, and so that doesn't change. So that doesn't need to be checked every time. So in the U.S., we tend to do that more at baseline. So maybe, as I said, our financial constraints are, although who knows, that could change, are a little different. And so we tend to run a panel of tests when somebody is first diagnosed, sort of, so we kind of are reviewing everything, trying to learn about everybody's individual CLL and what's unique to them. And so we sit down and we do a panel, very large panel, and then we sit down and discuss with them the unique features about their disease. But the counter argument to that, of course, is that, remember, prognostic markers are prognostic markers. They do not tell us exactly, I wish, this isn't lotto, I wish we'd be playing lotto if I can bank on my comments. They don't tell us exactly when somebody needs treatment. They give us guidance, so we might know that if somebody has, a high-risk feature, we can predict based on some of the history and historical studies that we have from CLL when they might need treatment, but that's not perfect either, right? So it really, the same applies about following somebody's tempo of their disease, their blood counts, their physical exam, and things like that are going to guide exactly when somebody really does need treatment. These markers just give us some information about that person's underlying biology a little bit, but we're not going to be saying, ooh, because you have this abnormality, I'm going to treat you sooner. We're not going to do that because, again, there's a learning curve, and we've all learned by doing this for many years that there's some patients who, on paper, look very badly, but then surprise us all and not need treatment for many, 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 many years. So we're not going to, the prognostic marker is not what's going to make us treat the person. But we do run a panel, and I know that's a little different in Canada, and my colleagues can speak because they tend to run that when you're going to start your treatment.
Yeah, I agree with what Nicole said. We in the US tend to get it's kind of a report card of your CLL, all things up front, but I think very important is the concept that the chromosome changes are really only in your CLL cells, because that can be something that really psychologically can affect you, and you say, oh, my chromosome have changed. No, if I do a chromosome test on your skin or on your hair, I'm not gonna find that change. That change is really unique to the CLL cells, and it's not in any other place in the body.
Yeah, that's a good
very
point to
important.
clarify. Dr. Banerji, did you want to comment, or Dr. Gerrie?
So the Canadian system, because of the public payer system, has approved testing at time of treatment opposed to diagnosis. And if we think, so I mentioned yesterday that, maybe only a third of the patients will go on to treatment, those are because I see a population-based practice opposed to a referral-based practice. So I have a lot more low-risk patients in my practice than maybe some of the referral centers. So it was decided that the testing would be funded because that's when it actually plays a role in decision making. So that's when that test becomes predictive instead of prognostic. So predictive means when we can actually use that information to make a decision about treatment. So this is where we would select the drugs based on the results of that test. So if you had an unmutated IGVH, then that would eliminate chemotherapy when we were using chemotherapy. If you had a 17p deletion, that would favor the use of a BTK inhibitor or a VEN-based therapy or BCL2-based therapy. So it actually predicted what combination or options for treatments patients would be provided. What's really interesting now, and we don't want to lose the testing because it does help us understand that patient, is that the treatments are getting so good that we're eliminating the differences between patients because of these tests, because of these excellent drugs. And so how this moves in the future will be interesting because we're eliminating the differences because the therapies are so good and they're able to overcome those differences in the biology of the disease. It doesn't mean that people don't relapse, especially when we're giving time-limited treatments or their disease isn't changing. So that's why we wouldn't repeat the IGVH mutation testing because, as stated, that kind of stays the same through your disease course, but you may gain some additional abnormalities. So the FISH test is the most common. That is something that is evaluating those chromosomal changes, but it's important to also understand that there can be changes within genes, and some of those genes, specifically the p53 gene, even though your chromosome is normal, the gene can be abnormal. So one of the things that we could do also is we sequence that gene to see if it carries an abnormality to help identify whether someone's in a high-risk category without the chromosomal change. So that's one thing. The other place where this type of testing is becoming, I would say, more important is certain drug-resistant mutations help us to decide potentially which other drugs could be used in the future. So we're creating an inventory through clinical trials, through real-world evidence studies, in cataloging the different mutations, mainly through research groups that are profiling patients' cancer when it comes back. Now, we're hoping this comes to prime time, but right now it's mainly being used in a research setting to potentially potentially say, if I got BTK inhibitor 1, could I still use BTK inhibitor 2 or 3? And if that's the case, then that actually, provides more treatment options in the future for an individual, because we have the ability to repurpose drugs that have already been funded within our environment. So there's a lot of information that we're gaining as time goes on, as our therapies have changed.
It's great. It's very thorough. So there is. Do you have access, Dr. Banerji and Dr. Gerrie, to p53 mutational testing, or is it FISH testing only right now?
So I can do all three.
Yeah, and that's the same in Ontario. We would have access to mutational testing for both IGHV and p53. Yeah. So I think there's that. Go ahead.
Yeah, I was just going to add, I think that we know that there are provincial differences. So that's what I was going to say. It's slightly different between provinces, but I think the key, and when you hear about differences between Canada and the United States, part of it is that we want to be fiscally aware here and ensure that we have the testing available for everybody when they need it. So a big thing in the Canadian healthcare system for most provinces is we're going to test if it changes what we're going to do. If we're just testing and it's not going to change what we're going to do in that period, maybe we can save that test for when we need it, we're actually going to make a decision based on it. So I think that's the viewpoint. I think it's actually very fair and makes a lot of sense, because it makes these tests more available for more people.
Yeah, and I mean, I think, I don't know, I can't read minds, but I'm just kind of think about what the minds might be thinking to that. I think the counter argument that we sort of hear in clinic a lot is, but I want to know. Yeah. I want to know my markers. I want to know what this means for me at this stage. And the difficulty is, I think, is you want to know what your future actually is going to be, and these markers don't provide that really. They provide a probability of a certain outcome, and we don't actually have the crystal ball yet. So that information can be processed in many different ways, and maybe it's not up to us to really define that. I think there are ways to get these tests done if somebody really does wish to get these tests done. But in the clinic, I think we spend a lot of time just trying to provide some perspective on what these tests mean. I mean, what if you get your prognostic marker studies done and it shows a p53 mutation? Well, now we've got potentially, honestly, years of active surveillance with the knowledge of this quote-unquote terrible mutation, not knowing, if this will mean you will need treatment in 6 months or literally 5 years. I mean, there's old data from MD Anderson and Mayo looking at the natural history of 17p deleted patients in the active surveillance phase, and fully half of them 5 years later still had not required therapy. The point being, that's a burden you have to be prepared to process and kind of go through with. So information is really important, and individuals do have to make their own decisions about what information is important to them, and I don't think it's for us necessarily to decide that. There are differences in access to the system for reasons that I think are quite reasonable. There's ways of getting testing done if there's, if you're able to afford, in all honesty, to have blood sent out. But you also just have to be prepared to manage what those results actually, mean, and the recognition that they really don't predict your future necessarily or tell you your future. They give you some information about probabilities of things happening. So it's a tricky conversation in the clinic. We spend a lot of time, I think, probably in the clinic trying to, navigate the decision making around this sort of issue in Canada, because, we do try to limit testing to what we think is going to help us manage, kind of your disease with you. But we appreciate the fact that, there's a desire to know as much as possible about your situation and to try to incorporate that into however you may wish to incorporate that, how you make decisions, how you live your life, and so forth. So it's a tricky one. So hopefully, this perspective of fiscal responsibility is sort of not at odds with, our desire to make sure that we have good conversations and support, kind of you in this phase of your disease. Okay, we do a couple more in this kind of active treatment, active surveillance phase. I think a couple of questions here around the concept, kind of the issue of immunocompromise. Two-part question. One, so would recurrent infections indicate a need for therapy? So that's number one. And secondly, we talk a lot about immunosuppressive modalities, but not a lot about methods to boost or strengthen the immune system. Are there any treatments or supplements that can naturally boost our immune system? I've forgotten where I am, so maybe Alina or?
Yeah.
Sure.
You did prognostic markers?
Yeah.
Oh, no, you all did.
Dr. Gerrie, well, I'm the moderator.
Okay, great. Yeah, so the concept of immunosuppression is such a hard one because it's not something that we can kind of grade and tell you, oh, you're a 10 out of 10, you're highly immunosuppressed, oh, you're only a 5, you're only a 1. We don't really have a mechanism, but we can get clues from a patient's kind of disease and their history. Some of the clues are you someone who gets a lot of recurrent infections? And as we talked about yesterday, this can happen even if you're newly diagnosed in the active surveillance stage. You might be somebody who gets a lot of infections. And it's often in CLL, it's often sinus and respiratory infections, so kind of upper respiratory sinus type infections that we see. So the first part of the question was?
Just is recurrent infections an indication that treatment might be
indication
needed?
for treatment. That's a great question. So I think various speakers talked about this yesterday. What we usually do is we check somebody's immunoglobulin levels, and that's a way to check your antibodies. These are just all the antibodies you have in your blood. In particular, we check one called immunoglobulin G. And if somebody is getting recurrent infections and they have low immunoglobulins, we can give you replacement for those immunoglobulins, and that's something called intravenous immunoglobulins, IVIG. And it's usually given through the intravenous, so intravenously, but there's now also a version that can be given subcutaneously, and some of you may be on these. So that is one thing that we can do if we see that somebody's having recurrent infections, and we kind of define that usually. Again, different centers will have different kind of guidelines about when to give IVIG, but generally, at least in British Columbia, we define it as having recurrent infections needing antibiotics, usually 3 or more in a year, or a very serious infection that led to hospitalization. And we try to give that to bring up those antibody levels. If somebody's still having recurrent infections, we obviously try to ensure there's no other reason. We treat the infections, but sometimes, I would say it's rare, but sometimes it is a reason to treat the CLL. If we're kind of at a loss and we think, it's likely just the immune dysfunction from your underlying CLL that is causing these infections, it's probably time to bite the bullet and try to treat the CLL. But it's a bit of a balance because, as we know, when we start treating the CLL, there's also a risk of infections from the drugs that you're going to be treated with. So we do have to balance it. But yes, I've certainly started some patients specifically for that reason, and I see my colleagues nodding here.
The only thing I was going to add is the discussion yesterday, the eloquent discussion about the immune system being so complicated is, unfortunately, even, if many of us who monitor these levels, unfortunately, they're really a poor surrogate marker for the immune system, because we have plenty of patients who have low levels and never get sick. And so, we kind of, as she alluded to, we'll say, okay, if you got, X amount of infections per year and a low level, we'll give you some gamma globulin to see if it'll help. And then, these medicines are also extremely expensive. And so we're, otherwise we'd be giving it to probably, 3/4 of our CLL patients who have low levels and may not need it. So there actually are clinical trials trying to address this, where we're randomizing patients to placebo versus gamma globulin to see whether or not does that really decrease there's a lot of unknowns about this area, and so we don't have very good data with regards to IVIG and CLL, or certainly not enough data in this area as a supportive. This is one active area we really should be trying to gain more knowledge to try to support you all better through infections and other complications besides therapy, which is, we always talk about therapy. but we need to talk about quality of life and infection stuff. And so there are clinical trials hoping to address this and see whether or not, does IVIG, really work? Does it cut down the frequency of need for antibiotics? Does it, how long should we use it for once you start it? There's a lot of unknowns, so hopefully we'll get more data in the near future.
That's good. Go ahead, Alina.
Well, I was just going to say for the second part of the question. Yeah, so I think the second part of the question is there anything you can do to boost your immune system? I wish there was. Unfortunately, there's not really that we know of, based on studies that have actually proven that any kind of intervention will help your immune system. So there are a lot of supplements and things out there you might read about online about immune boosters and such, but they're similar to our discussion about natural and some health supplements. They're just not studied in the same way that we would want to be able to recommend it to you. And we really don't know enough about the side effects of those and how it might interact with other medications. So in general, I would say there's no other things you can take. There are measures that I think we all learned during COVID, really, about how we can help reduce our risk of infection. And then, of course, all the things we talked about yesterday, particularly vaccinations, are a really important way.
Yeah, that's great. And I don't know if the question was also kind of getting at infections as an indication for CLL-directed therapy, but infections are not one of the indications to start CLL medications to treat the disease. And I think the list of indications for therapy was reviewed a number of times yesterday. And conceptually, that relates to a couple of other questions that were in here around, can you actually restore or improve immunity through treatment? It's not really clear. In fact, even our more modern treatments still have infection-related complications, and so you're not actually helping the underlying problem of low immunity and infection-related risks by initiating therapy. So it's not an indication to start CLL treatment, but the other treatments that Dr. Gerrie alluded to are things to consider for sure. We use a lot of immunoglobulin in Canada, I would say, compared to our American counterparts. That's probably true, I think. It's provided through Canadian Blood Services for us. I know subcutaneous immunoglobulin has been a common standard at many centers and is well tolerated. And again, I think the issues that Dr. Lamanna brought up about, what are the correct patients, correct dose, correct duration, those are real questions that can be addressed better through more research in CLL patients or hematologic malignancy patients in general, but CLL for sure. So hopefully there'll be more information coming, but an important thing to know about when reviewing things with your specialist that in the setting of recurrent infections, this may be a consideration for you. Great. Okay, I think we're on 9:30, so time's a flying here. We're going to move on, I think, to the paper-clipped group of questions that are dealing more with treatment. Hopefully this is okay for everybody. Can we get like a thumbs up or maybe a standing ovation in the middle of the... No, I'm kidding. Oh, yeah. Good. So this is kind of into the treatment bucket. I'll maybe just, I'll be curious to see, to get Dr. Ferrajoli's perspective on this very specific question. In the relapse setting, why venetoclax plus rituximab and not venetoclax plus obinutuzumab? So, and maybe some perspective in Canada. Currently, Ven-O is approved in the first-line setting. Ven-R is the standard of care based upon the Murano data in the relapsed refractory setting. And I think this is something that we often will speak about, the potential, benefits of obinutuzumab over rituximab. And there's data that I think clearly support that, especially in, the older unfit, populations that were part of CLL 11. But do you have any other insight into that?
No, I agree with you. It's based on the data that we have that show in the Murano data that it was done in the relapse that a different duration of 2 years of therapy versus the 1 year of therapy that is done as frontline, and a different partner for venetoclax, that is the rituximab rather than obinutuzumab, is what is considered standard and what is approved by the guidelines. However, personally, I do feel that obinutuzumab is a superior antibody to rituximab in patients with CLL with a deeper remission seen, particularly at the level of the bone marrow. So whenever I have the option, I will use obinutuzumab in the relapse setting.
Perfect. I think that's a good answer. I mean, I think, we make decisions around access to medications in Canada based upon high-quality evidence, and the high-quality evidence in this area is a randomized trial that utilized rituximab, and there is not yet a randomized trial in the relapse setting that confirms obinutuzumab is superior, and so our access is based upon, that data. So, but a good perspective that you shared around that. This is a question for Dr. Gerrie specifically, and then Dr. Ferrajoli. Do you have patients on venetoclax who have no end date? So do you have patients on indefinite venetoclax monotherapy?
Yeah.
Great question, actually.
Great question. Actually, when venetoclax was first approved, it was approved as a monotherapy. So when it was first studied, it was studied similar to the BTK inhibitors, where it was started and then just continued until people either progressed or had side effects that made them come off of it. And it was particularly approved for patients who'd progressed after a BTK inhibitor. So when we first started using it, there may be people out there, and I have a few in my practice, who've been on venetoclax monotherapy. We can still use it in that setting. And I know a number of colleagues still will consider that. So as an example, potentially a patient with deletion 17p who's been on a BTK inhibitor for many, many years, now is progressing, and you're going to start venetoclax-based therapy. Your options, you still can give, you can choose either venetoclax by itself, just indefinitely, or venetoclax plus rituximab, which is our standard in the relapse setting, and that's given only for 2 years. So there was kind of not really based on a lot of data, but just this general thought that people with deletion 17p, maybe we shouldn't stop therapy, we should just keep them on indefinitely, that maybe that's better. So I do know that some folks will consider giving venetoclax monotherapy in that setting. But actually some of the data that we see from the studies of ven with rituximab, the 2-year data, and then they actually continued to follow people afterwards to see, and a lot of people did start to progress after that 2-year mark. And so in the end, a lot of people won't be on it for more than 2 years anyway. So it's not really clear that keeping venetoclax going longer is actually better than giving it with rituximab for 2 years. And maybe it's fine to give it for 2 years, then somebody's off therapy for a bit, they start to relapse again, you could give it again. Maybe by itself at that point, or even, say by itself at that point. So we do use venetoclax monotherapy, but I would say it's not as common. But I'm happy to hear what others think.
Dr. Ferrajoli and Dr.
Yeah, I agree. I have probably just 2 to 3% of the patients on venetoclax in my clinic are on continuous therapy, and the very few that are on continuous therapy are because they have had multiple relapses and they have adverse prognostic factors. And the reasoning is because when we look at data with venetoclax in combination with CD20, both in the front line and in the relapse setting, and we follow what we have talked about yesterday that is called MRD, that is measurable residual disease, that is a very sensitive method to check how many CLL cells are present. We see a little bit of a difference between venetoclax and the BTK inhibitors. We see that venetoclax, after a certain number of time, the amount of residual disease tends to stop decreasing and at times starts increasing, whereas with the BTK inhibitor, we tend to see more of a continuous improvement over time. So this is also one of the reasons why venetoclax is most commonly used as a time-limited.
Great. Dr. Lamanna, are the newer BCL2 inhibitors just as toxic in causing severe neutropenia? Is neutropenia a real concern with all BCL2 inhibitors? my current hematologist is reluctant to consider BCL2 inhibitors due to its toxicity. So what's your experience in managing people on BCL2 inhibitors?
This is a perfect, you did such a nice order of the
Yeah.
questions. It flows so good from the others.
These
I mean, this
questions
goes
are
back to
from
the
them.
sort of the development of how these drugs got used and truncated and why the venetoclax therapies are more time limited in general. You know, because it does do a better job at mopping up the bone marrow than the BTK inhibitors. And so we do see more cytopenias in general with the BCL2 inhibitors. Now, that doesn't mean that we shouldn't be using them just because there's more neutropenia. I think that needs to be, you know, clearly monitored during therapy, and we all probably have different strategies about how we modify the treatment, you know, depending upon if somebody's getting recurrent neutropenia, if their neutrophils are getting low. Sometimes we'll dose reduce the drug, sometimes we'll give growth factor shots to support them, but oftentimes if somebody is getting lots of neutropenia if they've been on the drug for a while, and if we were to look, some of these patients really have, as Alessandra just noted, you know, undetectable or very little residual disease, and their bone marrow is, you know, clean, and so sometimes, again, you can stop therapy. So, you know, it does cause more neutropenia than the BTK inhibitors, but we need to monitor, and obviously we talk about, you know, if somebody's neutropenic, that if they have any fevers or any signs or symptoms of an infection, they need to bring that to our attention. So there is, the mechanism of the drug is different, and so the reason why it first started as monotherapy, and then when we saw the profound impact it was having in the bone marrow with mopping up the disease, you know, adding a CD20 monoclonal antibody like rituximab. So this is what led to its time-limited approval in the first place, was the study that she alluded to, this Murano study with venetoclax and rituximab for 2 years, because it was able to have many patients develop undetectable disease in their bone marrow, and we can stop therapy. So all of a sudden, this monotherapy drug became time-limited, like what we used to do in the chemoimmunotherapy days with FCR and bendamustine and rituximab, that we can make a time-limited approach because it was able to give these deep remissions, and you can say, hey, we can give a break to this type of therapy. So that's kind of how it evolved historically. So yes, there is more neutropenia with the BCL2s. With the newer ones, you know, we still are seeing some neutropenia. Obviously, this data is a little young, but there is neutropenia with the newer ones as well. And again, similar guidelines about how we modify either the dose or support of the drug while people are neutropenic. So it shouldn't be, yes, it's a known side effect of this class, but it doesn't mean that we shouldn't be using this class. We just have to appropriately deal with it, just like we did in chemotherapy days when we gave chemotherapy and there was neutropenia associated with that. So it's something that is known, and adjustments need to be made accordingly.
Yeah, I agree with all of that. I think, in fact, I think probably most of us would agree the tolerability of venetoclax has actually been excellent. I mean, the cytopenias are probably the most common clinical problem that you deal with, in, you know, kind of in the clinic. But
GI.
What's that?
And the GI issues.
Some-
I think,
Yeah,
you
so
know, I think the cytopenias and the GI issues are really the most common things with
Yeah.
the BCL2 inhibitors, are the nausea and some the diarrhea. So, you know, those things are probably, you know, more troublesome from a patient perspective as we deal more with a lot of the GI issues.
That's great. So the next question is, again, a nice segue from this discussion, I think. And Dr. Banerji has the challenge of dealing with MRD testing in Canada. So is it a standard in Canada to have an MRD level checked after treatment?
That's a US
Since Nicole, Nicole used those words about 5 times in the last 10 minutes.
So I think so measurable residual disease, or MRD testing, has become used within clinical trials to help us understand how the drugs are affecting the different compartments within the body. So we can do the test in the peripheral blood, and we can do the test in the bone marrow, and we can use different techniques to identify the level of those cells that are wearing that same clonal uniform within those compartments. So the first question that was studied was, if we do it in the blood, is it the same as if we did it in the marrow? And I think we now have a better understanding that if we do the bone marrow and the blood, they're almost equivalent. So hopefully we can save patients from having to have a bone marrow test, because it is an uncomfortable test. But as we're doing the clinical trials, we really want to be sure. So most clinical trials will still have that measurement done within the bone marrow test. So one of the questions that we're trying to answer is, if you have no detectable MRD, or there's none of those detectable cells in either of those spaces, does that mean your remission will be longer and you potentially will not require treatment in the future again? Because hopefully, like we saw in some of the old chemotherapy data, maybe there's a subset of patients that could potentially achieve cure. So that's the question that's trying to be answered. Now, we're not basing our current treatments, at least in the Canadian environment, on whether or not you should treat someone further if they have what we call measurable residual disease, or if that MRD is positive. But there's clinical trials within the United States that are currently evaluating whether, let's say we gave you something that is a fixed duration, and at the end we measured if you had MRD positive or negative, and then we would design the study to say, well, let's keep going on one of those medications until we get you to the point where there's no more disease present. And so it's being used as a tool to understand what's the best sequencing strategy or consolidation, which is adding another drug so that we keep you in remission longer, for the potential of potentially eliminating treatment from the patient journey. But we're not really at that point, and it's really being used as an investigative tool. Now, there's some people who would like the test because if they know that their patient has residual cells after they've completed a time-limited treatment, the question is it better to add that extra bit of drug so that you can get them into that deep remission with the hopes of stopping any further treatment? Because currently the philosophy is similar to that curve that I showed yesterday, which is, we treat you, we get you into that deep remission, and does it matter if there's those little cells that are there? Should we just wait until those cells come back and retreat you again? Because at least we provide you some quality of life and some time off treatment during that gap. So right now we're starting to learn whether CLL is a disease that we want to get to MRD negativity with the new drugs that we have. We understand it in the context of chemoimmunotherapy, but I'm not sure that we understand it in the context of the new treatments at this time.
That's great. That's a very, very comprehensive answer. Was there anybody else who wanted to add anything to that?
Yeah, I think
Gerrie?
I'll just add that it kind of comes back to that same concept we talked about, prognostic markers. The test is available, well, not necessarily available everywhere in Canada, but it is a test that's out there. We could do it. It might give some information, but we're not going to change what we do based on it. So at this point in time, it's not helping us guide treatment. It's not helping us guide when you need treatment or what kind of treatment you would get. So it's not a test that's readily done in Canada yet. But as Dr. Banerji was saying, there's a lot of studies that are ongoing looking at doing the test at the end to help decide if you should keep going with more treatment or not. If those actually end up getting show benefit and get approved in Canada, yes, this test will get approved and will be used regularly in clinical practice. But at this point, it's not going to change what we do, so we're not really routinely doing it, apart from maybe in a research setting or if you're part of clinical trials.
Fantastic. We're going to stick with you, Dr. Gerrie, for this next BTK inhibitor question. So this is a question around ibrutinib versus a selective second-generation BTK inhibitor. So are the second-generation BTK inhibitors preferred because they work better or because of an improved side effect profile? And the second follow-up question is, if you are on ibrutinib, should you switch to the second generation? Yeah.
And we get this question from physicians also who treat lymphomas and CLL all the time. It's a conversation that we've all been having regularly. So I think it's now very clear that ibrutinib, that the second-generation BTK inhibitors have less side effects, particularly the cardiac, the high blood pressure, and then some of those other side effects we talked about, gastrointestinal, skin, nails, joint pains, muscle aches. So when we're starting people on a BTK inhibitor now, we will use the second-generation BTK inhibitors. The one caveat to that is that currently in Canada and soon to be funded in most provinces is the combination of ibrutinib with venetoclax. And so far, the combination of a second-generation BTK inhibitor with venetoclax, like acalabrutinib with venetoclax, is not approved. And that will there'll probably be about a year or two gap until that's approved. So there might be cases where we consider giving ibrutinib still with venetoclax in certain cases, usually to younger patients without a lot of medical problems. That being said, and in terms of whether it works better, I think the second generations work better. We don't really know. It's not clear. There was one study with zanubrutinib that was compared head-to-head with ibrutinib in the relapse setting, so patients who'd were using these drugs for relapse disease. And it did show that patients who got zanubrutinib had longer time in remission than patients who got ibrutinib. And there is some rationale behind that. The way the drug was developed, it possibly does bind a little bit different to the BTK and can maybe result in longer remissions. So potentially, but I don't think it's entirely clear. And so then, but the thing is, so even though now we'd prefer to use second-generation inhibitors, ibrutinib is still a great drug, and we used it in many patients when it first came out, and we do have a lot of people still in our clinics who are on ibrutinib. And the general feeling is that if someone's tolerating it well, they've been on it for years, it's not causing problems, we don't need to switch. We can carry on it. I'm usually pretty quick to switch if something happens. Say a person is starting to develop high blood pressure, or maybe they do get a heart problem, even unrelated, some kind of heart thing comes up. I think, maybe now's the time to switch to one of the newer drugs. But in general, if someone's tolerating ibrutinib well, they've been on it for a long time, I wouldn't say that we need to switch. Or would you? Similar?
Yep, I think that's sage advice. Yeah, great.
We all agree.
We all agree.
Phew.
No, I'm not going to comment any further on that. So, Dr. Ferrajoli, the next question is, so this is actually, again, this needs some Canadian perspective. So are there studies regarding familial CLL? And I think the question is perhaps getting at, is there an opportunity to participate or perhaps provide samples, or is there something that patients who have CLL may wish to consider to help understand this issue of the familial clustering of CLL?
Yes, so there is a consortium that works on familial CLL. It's coordinated by the Mayo Clinic, and we participate too. And there is a possibility, I'm sure, that other centers can participate. And we also have a genetic leukemia clinic at our center that is run by one of my colleagues, where we will be referring the patients so that their siblings and family member can be evaluated and tested for any predisposition toward leukemia. And this is very important because we see some clustering of CLL, but also clustering of an increased risk for various types of cancer in family members of patients with CLL. So those are the two initiatives that we have at a nationwide level. We collaborate with this consortium for familial CLL, and at a clinical institutional level, we often specific counseling where the family tree will be constructed and the available siblings will be tested if they wish.
And do you tend to refer specific patients for that sort of testing rather than everybody?
We tend to refer to this clinic the patients that have history of CLL in their family and patients that have a history of a really high number of cancers in their family.
Yeah. Right. Any perspective, Versha, on that, or Alina?
So I think I'll break it up into two parts. So if we usually do a family history when we're taking the initial assessment. And if we do identify that maybe your family history does have a strong predisposition to family members with breast or colon, then we would make a referral within our system to the familial kind of genetics counseling service that we have to make sure that there isn't some genetic predisposition that would kind of identify that. And sometimes the patients will tell us, oh, we've already been referred, but we do try and make that. When it comes to the leukemia piece, we have participated in the genetic familial consortium that's run through the Mayo Clinic as well, and we were one of their sites. But we have not done that as part of the clinical care piece, but more as part of a research project to try and understand familial CLL better by contributing to the ongoing literature and studies that are taking place. So we don't really have a specific I would say, non-research-based clinical practice of referral where patients could come in and get that type of counseling. It would be study-specific, and right now we don't have any open studies. So I would say more for the solid tumor pieces where there's systems in place to evaluate and contribution to research endeavors across kind of the globe to try and understand the blood perspective.
Yeah. Did you want to add anything?
I think the one thing that for those interested, if this relates to the question or not, many centers have a tissue banking, so to speak, where we collect, think about it, at least for blood cancer patients, the fact is that your cells are readily available, which makes prime for future and endeavors on research. And so many of us will have volunteers of you all to give an extra tube of blood so that we could bank those samples. And when, ideas come around or projects come around, we have banking of the CLL cells so we can, either go back retrospectively if we find a new marker, or if we're looking, or there's something prospectively in the future where we're like, oh, this is a great thing, we should look for this. And so people can often sign up for those for an extra tube of blood that's anonymous to various tissue banking centers. So
that's great.
Shameless plug.
That's super helpful perspective. So, I mean, maybe to summarize, really this remains fairly firmly in the research realm, and if there's a strong, kind of question or desire to participate, it's probably something to review with your CLL specialist, and they may be able to, kind of arrange samples to be provided, but it would be largely within a research perspective as opposed to, making decisions about clinical, kind of testing or decision making in other family members and so forth. So I think that's maybe the synopsis there. Great. Dr. Lamanna, are there CLL studies focused on women?
Oh, that's a great question.
It is a great question. Yeah, I agree with
I
you.
wish.
Great question for all.
That's a great question. And it's an all-women panel. Look
It's
at
an
that.
all-women panel.
Right? No, there's not. As we reviewed, this disease has more predilection for men than it does women, but that's a great question. There are probably some subtleties. We noticed that, women may have some more indolent features of their disease. We've even had some abstracts and things about, women who are younger and have CLL and have given birth. So that there is some retrospective stuff, but there's not necessarily, unless Alessandra knows, necessarily a true separation of research that's totally dedicated to looking at this disease separately from women versus men. But I'm all for that. It's just we haven't done that, to be fair.
Great. We're going to finish up with just a couple of more questions, and this is kind of going to move a little bit back into the advocacy realm, I suppose. So there's several questions related to engaging with primary care providers, with family physicians. So, I'll read off a couple of questions, and we can kind of put it to the panel. How can primary care physicians be better informed about CLL to better advocate? some challenges that somebody experienced in terms of specialists making a recommendation around vaccination and not being able to see those recommendations carried out through their primary care provider, or that it should be provided through the hematology clinic. Yeah, I think that's probably you get the general gist of it. I think, how should a CLL specialist and patients be interacting with the primary care team, which are honestly so critically important for many aspects of care? Perhaps, I think Dr. Banerji is next in line for this one.
Yeah, so I always, when patients are referred, they come through multiple different streams. Either it's like through the emergency room, where because they came with an elevated white blood cell count, or through their primary care provider. So when the consultation occurs, I think of it as a partnership by myself and the family doctor to take care of the patient. And the recommendations that I make also include a little bit of education within the letter back to the primary care provider. So what conclusion did we come to today? What are the things that we're looking for? What are the parameters or the blood levels that I'm concerned about? And what should the patient bring to your attention or my attention? And then I do a series of recommendations on the vaccinations and the primary care and the primary cancer screening for secondary cancers. And so I put all of that in my initial consultation level. I also put where the vaccinations can be found, and that they may or may not be covered, and that we would ask for their help in organizing these pieces. So I'm very direct, because our clinics also don't have the capacity to do the vaccinations, and it's not part of the cancer agency's program, at least at my institution, and that could differ between the institutions. Now, not all of the vaccines are actually covered if given by the primary care provider. So it is important to know that some of those purchased vaccines could actually be delivered by your pharmacist as well. So there's other ways of accessing those vaccinations if they can't be given through your primary care provider. And I think what you're bringing up potentially is maybe something that we need to do better. There's been a huge change in CLL over the last decade, and maybe we owe it to the primary care providers to provide better education so that we can ensure that the patients are receiving the best option for themselves, because there has been a significant amount of change in the practice. We do try very hard to educate other hematologists and transfer that knowledge at the specialist level. In my province, we have something called Blood Day, which is actually an education session for primary care providers. And actually all those talks and all those guidelines for every blood cancer and blood disorder are available online through the University of Manitoba. So it's definitely a reference that can be used. But we do try and update our primary care providers every couple of years on some of the new changes that are happening. So I think for us, it's to hope that we can partner with the primary care providers and provide them with the most up-to-date information so they can better serve you.
Dr. Lamanna?
Yeah, this is a tricky question. I'm going to be honest. I think, you're here because you're your own advocates, and I think that's really important. And there might be financial differences. I'm not going to talk about those, because there are restrictions, I think, based on provinces of where you live in Canada, and I appreciate all that. And obviously, these guys know this best. And so you have to work with both your primary care and your oncologist to figure out how to get your vaccines and things like that. That's, what you guys have to do. And I think that makes complete sense. I think what you guys need to, when you have your hematologist, oncologist, your leukemia physician, you need to ask them how do they want those calls to be fielded? If you get an infection, are you calling your primary care doctor, or are you calling your hematologist? And so there's some of us who will say, I want you to call me. And there are others that let me partner with your primary care. If that's the person you have a really good relationship, as long as they're okay with it, I want you to call your primary care doctor. You need to establish these guidelines with your physicians and your teams, because I think this is unique to, each of our practices are different. We all work in different ways. Our practices are, however we practice may be different from one setting to another setting. And so given that you're your own advocate, you need to figure out how your routine is with your local doc. And you need to be honest and direct, because otherwise you're the one who's going to suffer in the end. So you need to figure out who you need to call, and that is an important, so you know the line of command that if you need to get to somebody, who do you access? Am I calling my hematologist if this is a problem, or am I calling X? Obviously, if it's directly blood related, you're going to be calling your hematologist. But some of these other things like infection or other medical problems, there's blurring of the lines. And so I think you just need to establish that relationship going forward so that you know where you need to go to, so that there's no question and that you can get the attention that you need. And for me, that's all I care about. And so I think that's really important.
Yeah, I agree. We do the same thing. There is a lot of variability also, at least in the US, of how much your primary care wants to be involved. So we have a series of checklists with things that need to be done, blood work that needs to be done, and we really work through still paper communication back and forth. And the patient, you are the owner of this communication. So I agree with both Dr. Gerrie and Dr. Lamanna.
Yeah, good communication at all levels is really key between physicians and with yourself and physicians, and so I think those are good messages. We are just over time. So the speaker, the doctors panel is now officially closed. I'm sorry if I didn't get to a few of the questions. It was an excellent panel. I'm just going to say that I think all of our speakers are likely going to be leaving the meeting for other research meetings and other obligations now. So I just want to take this opportunity to, again, just really thank all four of you for coming and supporting this meeting and supporting the patients that are here. Your involvement has been just exemplary. The talks were incredible. This panel was fantastic, mostly because of all the great questions, but they have to be answered with great answers. And so thank you so much for participating and for your questions. And this is definitely a time to stand.